Oh,
Just
there we
turn
go.
it on.
Live. Okay.
Okay. Good evening. This is Dr. John Bennett from Miami, Florida. Tonight we have the pleasure of having Albert Huang, MD, who's doing his own created fellowship at Methodist Hospital in Houston, and he'll describe it. It's more or less a medical device fellowship, which hopefully will continue on after Albert goes on. Anyways, Albert is going to tell us about what he's doing with Google Glass and industrial design. He's probably one of the only doctors you'll run into that has a background in industrial design. But I'm looking forward to hearing Albert speak. So good evening, Albert.
Yeah, hey, good evening. Thanks so much for the kind introduction, John. So, as he said earlier, my name is Albert Huang. I am about halfway through my general surgery residency training at Houston Methodist Hospital. And right now, I'm 1 year into a 2-year fellowship in sort of medical design and innovation at MITI, which is the Methodist Institute for Technology, Innovation, and Education, which is also at Houston Methodist. It's an entire floor, $40 million facility where we have the resources and all the people to come in and test new devices. We have companies come in. We do training and simulation as well, and we also do, of course, education of surgeons both within the United States and around the world. It's sort of this perfect ground with all the resources available for us to test new devices such as Google Glass, and with sort of this increasing movement of wearable technology, we've really sought after this material and these technologies and are trying to pull it in and see what can we do with it in a hospital setting. So over the last several months, we've worked on a bunch of different projects. Almost all of them are revolved around Google Glass. We've done some work on our own, but I also did want to mention that we have partnered with Pristene. The CEO is Kyle Samani, who gave one of these hangouts probably about 2 weeks ago. So Kyle and his company have been really instrumental in providing us equipment to let us see what we can do with it and really try to push the wearable technology, push glass to see how far can we really take it, what are the limitations, what are things that we see it being viable for in the hospital setting. So I put together a sort of a very quick PowerPoint so you don't have to all look at my head only. So I'll kind of load it up here. If you give me a brief second. Let's see.
So just quickly, Albert, you don't deal with patients, right? It's just checking the machinery and.
So right now, I don't have direct patient care. I have gone to the operating room with a number of our surgeons, some of our staff. I also do some other studies that do involve patients, but in regards to the day-to-day, as if I was a resident, I'm not doing that right now.
Okay. Just okay.
So I don't have to wake up at 4 o'clock in the morning, at least for the time being. So. So let me see here. Are you able to see my screen, John?
Hold on, not yet. Let me, not quite yet.
Okay.
Are you clicking the green arrow there?
I thought I did. Let me see. I think it exits itself out again.
Sometimes it slips off.
Here we go. And
I see my screen.
Okay.
There, okay, there we go. The testing the capabilities. It didn't stay up there yet. Sometimes it delays a little bit.
Okay.
There we go.
If it's, okay.
Testing the capabilities of glass.
Yes, absolutely. So this is sort of just our test screen, just to make sure the whole system works. So.
Okay. Tell me when you change slides, so I'll alert you if it does not change. Sometimes it freezes. Okay.
Gotcha. I just changed to one slide over.
Okay. We're still on the first slide.
Okay. Is it still there?
Yeah, projects and pilot studies.
Ah, very good. Okay, so this is the one. So these are sort of the 4 things that we've done with glass and wearable technology here at Methodist. The first one, and I'll kind of go through each one in sequence. The first one is the LAPCO initiative, and this is something that we have been bringing over from the UK, where they did a laparoscopic colon surgery initiative, where they're training their surgeons in all the hospitals in the UK on how to do this procedure. And in doing so, they've developed a very specific language, command set, and teaching methodology so that both the instructor and also the trainee surgeon that's getting trained in how to do these specific operations are on the same page as they proceed through the operation. In the UK, when they do this, since there are no issues with um, hospital rights and privileges between institutions, one surgeon can go to another hospital without a problem. Whereas here in the U.S., not only are we geographically limited, but the surgeons are, of course, unable to fly from one state to another, or even within the same state, and go to the operating room in another hospital without credentialing issues. So to sort of sidestep that or address that issue, we were looking at aspects of telementoring built into the LAPCO initiative that we brought over from the UK. The next thing I'll talk about briefly is just in general the usage of glass in the operating room as a training tool, education tool, also a way to keep everybody in the operating room on the same page so that the case flows very smoothly. We're also going to be using it in the our surgery and liver ICU. We have an ICU here at Methodist Hospital that has at any given time at least 50% transplant or pre-transplant liver patients, which are very complex patients, as many of you would know. We get admissions anytime throughout the day or night. These patients are, of course, on multiple drips, medications. We have lots of values to look at, and our thought is that to keep our transplant attendings and our hepatologists up to date with things at night, if we use something like glass as our platform, instead of having values read out to them at 3 o'clock in the morning, the attending that's at home can now see virtually into the patient's room, evaluate the patient themselves, and serve as a second set of eyes along with the resident that may be on call. And then the last thing is, of course, just in general usage of glass as a training and an education tool, recording procedures both in and out of the operating room, using it as a first-person perspective to show other people during an operation what the head surgeon is looking at during the procedure as well. All right, so I'm on the next slide now, John.
Yes, it did go off.
Wonderful. So again, LAPCO. So this is the Laparoscopic Colorectal Surgery Training Initiative. The date below is when we brought this to the U.S. and specifically to Mighty here at Houston Methodist. A number of certified LAPCO trainers were brought in from the UK. They flew over, took their time out of their busy schedules to come over, and we did a session where we did training the trainers. So we have our own group of colorectal surgeons that are well versed in laparoscopic colon operations here in the Houston and Louisiana area that came in, and the trainers from the UK came in and taught them the system. At the same time, we use this opportunity to introduce all the members of the teams to glass, specifically the Pristene platform, Kyle Samani's platform, Eyesight, into the system here. And you can see one of the UK instructors and with one of our other fellows here practicing. So sort of below the screen and out of field of view is we used a cadaver, and what we did is all the other members of the team are sitting in a conference room about 50 feet outside of the space here, so everybody can see what the person wearing glass is seeing, and that person is looking at the screen that the laparoscope is projecting. So they're able to see everything that is going on and that the operating surgeon is doing in the field, and an entire room can see everybody, which is very nice. So it worked out quite well. We had a couple connectivity issues at that time, but once everything got set up, all the members of the team really enjoyed it. We actually had them fill out a number of questionnaires in regards to their experience in it, and we'll be presenting a small paper at Texas Surgical Society, and ultimately it's going to be a part of a larger paper on wearable technology and its usage in the operative setting. So next slide. Moving on to usage in the operating room. The picture here is Dr. Robert Ochoa. He's one of our staff surgeons at Houston Methodist. He's also the director of the surgical ICU. So you'll see there's some overlap in people who have interest in this technology in our surgery field here. So on June 13th of this year, we did the first reported usage of glass in the operating room in the Texas Medical Center, and most likely in all of Texas, although I got to confirm that. It was Dr. Robert Ochoa pictured here and myself. I was running this camera, so I'm not in this picture at least. This one was more of a proof of concept. We wanted to have glass used in a true operative setting, and of course to do the first version for the first usage of it, we wanted it to be a very straightforward classic case. So we chose a laparoscopic cholecystectomy on a patient done in a non-urgent setting. Everything was very well controlled, pre-arranged, all set up, and so everything could run smoothly so we can focus on, of course, patient safety being paramount and not having to fiddle with the technology too much. So we performed a lap chole. What Dr. Ochoa saw firsthand during the operation was projected onto a flat screen within the operating room, allowing, we had medical students, residents, nursing, and nursing students. They could all see what he sees. So they could see, was he looking down at the abdomen, was he looking back up at the screen, and at the end of the operation when he's closing the wounds, what was he looking at, what was he looking for. The nursing staff, very interestingly, found it very helpful to know what instrument he's using at any given time. Certainly the scrub tech knew, but the circulating nurse could see, oh, he's reaching for these things, or he's sewing this wound closed and he's going to be needing more of this suture. And without Dr. Ochoa having asked for it, things were actually brought into the room. So kind of inadvertently, we realized that this could also be used as a operating room efficiency tool. Everybody remarked that it was a very easy system to use, very much out of the way. It was very natural and intuitive and didn't generate more friction in the operating room or in the operative setting, both for Dr. Ochoa and also for the rest of the staff. So a couple more pictures. Over here you can see Dr. Ochoa. So he's doing the procedure here and looking at the screen while wearing the unit, and then on the right side you can see the monitor where you can see exactly what he's looking at. So of course during most of the operation he's looking at a monitor that everybody can see, but as he looks around and as he's directing his camera, reaching for instruments, you can really see what he is doing in a very specific and kind of very personal way. So you can see his movements, you can see why he chooses certain things, you can see his hand positions. These are all things that even though you can see what he's doing on the screen, a trainee surgeon or nurse has an idea of why he positions things a certain way. So there was definitely a lot of education and educational experiences to be learned from this. So kind of near the end of the procedure, here's me and him in the field, and Dr. Ochoa, of course, just closing up the trocar sites. And here's where we really saw glass kind of offer a lot more in terms of being able to see something that only the surgeon himself was seeing. So if you work in a very small operative field, a very tight, narrow space, things such as urologic procedures, gynecologic procedures, APRs, things where you're working in a very small space and maybe only one or two surgeons have that perfect view for training purposes and for everybody else to see what is going on. Usage of something like glass is absolutely wonderful. Everybody gets the exact same view as the person who has arguably the best view. So here's the end of that procedure, and several pairs of Google Glass. Some of them are our own pairs, and then some of them, again, are from Pristene. So left to right is Dr. Robert Ochoa. That's me in the middle. Dr. Victor Wilcox is back there, and then one of the other residents who was involved in the operation, Dr. Tony Liu, is on the right side here. So this is a full team effort. It's not really driven by one individual. It's everybody at Methodist is on board with using new technology and really seeing what we can do with it to improve patient care and education.
Well, you know, I wouldn't want to run into you guys in a dark alley.
With all these little glowing screens, right? So, kind of moving on through to the liver and surgical ICU slide here. Once again, Dr. Robert Ochoa, who worked with me to do the simple, lap chole that we did earlier. He's the director of the liver and surgical ICU, and we sat down and had many conversations about how things work in the ICU. How do we manage patients safely and do continuity of care while still working within the boundaries of resident work hours and regulations, and even just the natural shift change that occurs with attendings as they go on and off call. So glass really is something that can bridge that gap. The attending that was on call during the day may as well be the one that's on at night, but if they're doing home call, glass now gives them the opportunity to see into the ICU. They can see the patient they saw earlier in the day, and they can say, yes, this patient looks worse than what I saw 6 hours ago. At the same time, any one of the attendings who's on at night, if a resident says there's a new patient that's here, these are their lab values, these are their vital signs. If it's a very complex or sick patient and 3 o'clock in the morning, it's way easier for somebody to process both visual and audio data together than just listen to a bunch of numbers of lab values being listed off at night. So for safety, efficiency, and just overall training purposes, to have a unit of glass where you go there, you just look at the patient, look at the room, and you're talking to the attending at the same time as you're there, we think just can completely change the way the ICU functions, especially at night. Also, of course, during the daytime, if the attending is managing another sick patient over in the operating room, having to manage or take care of something else, the other members of the team who are in the ICU can just put on glass, and the attending can now just access their cellular phone or any sort of portable cellular phone device and be able to see back into the ICU with just a moment's notice. So we really plan on using it to communicate patient details and status, both between attendings, to attendings, between residents, and we want to use it both day and at night, although we see a huge promise in using the system in the nighttime. The other thing we want to do in the ICU is that this is where traditionally a lot of residents get procedural skills training. They learn how to place Swan-Ganz catheters, place central lines, cortices, dialysis catheters, do they do all sorts of taps. They'll do they'll drain some peritoneal fluids, especially when we have these liver patients. We need to tap the ascites to see if they have spontaneous bacterial peritonitis. These are all procedures, and what we've traditionally done is we have one person show the other, and both people have to be right there. And we've never done anything where we have a 3-minute or a 5-minute video that shows the procedure in a first-person perspective. Every single resident attending will tell you that they've had many, many times where as they walk a trainee through a procedure, at some point they need to put themselves in the same exact position or right next to the trainee and show them how it's done, because the trainee, although they watched the procedure done before, didn't see it from a first-person perspective. So things like angle of the needle and little things like the feel and the sensation, hand placement, these are all things that are a little bit more subtle, and these little fine skills can probably, hopefully at least in some part, be communicated if the video is shot from a first-person perspective that glass can offer. So that's what we're hoping to do, and we're working on designing at least a questionnaire-based study around it to look at the efficacy of this thing, hopefully from at least from a subjective perspective, and see if we can demonstrate some level of validity to some of our hypotheses in this situation. And then, of course, there's education and training. Then this sort of builds on everything that we hope to use it in the ICU for. Recording of procedures and techniques, both in and out of the operating room. If there's an interesting case, things that don't show up very often, but that you're going to be asked on board exams or on tests or things like that, or just things that are just related to finesse and technique, by using glass or another wearable recording device that's completely hands-free, you now have the opportunity to make a big collection of these things, and it's a treasure trove that can either be put online or just used internally or in-house for the residents to be able to view these operations, some of these more historic cases perhaps. So on the right side here, in conjunction with the Department of Urology at Baylor, the surgeon here is wearing a Vuzix system, which is loaded again with Pristene's Eyesight system. And we angled it down slightly, and they're working in a very, very small field here, and they're doing an open prostatectomy. So their department does a whole lot of them robotic now, but occasionally they will still do some in the traditional way. There's a lot of finesse, fine motor skills involved, and very clean dissection maneuvers, especially when they're stripping the lymph nodes off of the iliacs during the procedure that really at most 2 people can see that view because they're working in a space that's maybe 3 or 4 inches across. So having the Vuzix seeing exactly what the surgeon is doing, recording that procedure for later viewing by all the trainees is really a valuable resource. So, and that's essentially what I've said here on this slide. So kind of closing up, you know, what's next? There's a number of things. I mean, the glass is sort of, in the sense, like the commercial version, the first of its kind. We're definitely going to see more versions out there. There's already glass. There's already Vuzix. There's a company that has been offering pre-orders for Meta Glass, which is a binocular system that projects overlays, which, in my opinion, may have better usage in an OR setting since it's both eye protection, lets you see through it, but also can project onto your field of view and interact a little bit with your field of view, which makes it a very fascinating device. But all these systems have at least some level of issue with connectivity. And I think that's just something that's going to happen with this, just like with cell phones evolving from 3G to 4G. Eventually, these units will get better and better, and we won't have issues with connections being dropped or with video quality dropping because of a slight fluctuation in web connection or wireless connection. Lag in the video and in the audio kind of goes hand in hand with the connectivity. There are ways to sort of fix this or make it a little bit better, you know, using the little 4G hotspots when you travel around, having the glass connect directly to the Wi-Fi of the hospital that you're at. We've also experienced some good success using things like the MacBook as a Wi-Fi hotspot. If you're working in the operating room, you plug the Mac into the Ethernet cord, into the wall with the Ethernet cord, and then you use the Mac as your hotspot, and we get some great connections that way. The other 3 things that we've had issues with, or things that we found out that we needed specifically through telementoring and our experience with LAPCO, is something called teleillustration. Dr. Brian Duncan, who's one of our heads of MIGHTY, has been spending a lot of time and a lot of his energy and experience in researching telementoring. And one of the things that he knows that is absolutely integral is something called teleillustration, which in the easiest way to explain it would be if you watch ESPN and the sports commentator draws that line showing you where the ball is going on a football game. That's sort of what we need to do in the OR setting. So when you're talking to a surgeon and you're trying to show them the picture that they're seeing, and you're trying to tell them, oh, you need to be in this plane right here, or you need to look at this structure up here, instead of doing what we call verbal pointing, which means you just sort of tell them and they're trying to find it, you say yes and no and yes and no. If you're able to draw a line or circle something and project that back for the wearer, then that is more efficient and, of course, much safer for the patient, too. I know that Kyle is working on teleillustration, and once again, this is something that will, with time, be made available in some form or another. Also, two-way communication is something that is absolutely integral, both audio and visual. This allows almost like a webcam style interaction between instructor and trainee, the surgeon and surgeon. It lets you know, if you're wearing the unit, who you're talking to. Although you might hear their voice, it's really nice to have a true two-way communication. And then finally, kind of linking to that connectivity and that lag, is the issue of resolution. One of the things that we found out is that if we wear glass to look at a screen projecting what the laparoscopic view is, and then you're trying to see that from another room through the glass unit, it's very hard. The resolution is it's low enough that you can't distinguish tissue planes. It's high enough that you can see what people are doing, but in terms of safety and efficacy, you really need to have some very crisp and clear video being transmitted. And again, along with the connectivity, these are all things that will get resolved down the line, just with the natural progression of technology as well. So all these things, I think, will be fixed eventually. So, of course, I have to do my acknowledgments. Again, right now I'm a research fellow at the Methodist Institute for Technology, Innovation, and Education here in Houston. It's the Houston Methodist Hospital, the largest hospital in the Texas Medical Center, which is the largest medical center in the world. So, kind of a big place. The land of Dr. Michael Debakey as well. So, I'm really honored to be training and working and doing research and innovating in a place that's kind of special like that. So, the people that have all been integral to both the institution and also these projects that we've been pushing forward are Dr. Brian Duncan, Dr. Barbara Bass, who's our department chair, Dr. Mark Garby, who is really responsible for doing a lot of device innovation here at Methodist, Dr. Victor Wilcox, who's another research fellow in conjunction with me, Dr. Robert Ochoa, who is director of the ICU here at Methodist as well, the surgical one, and then Dr. Monty Azgade, who is a urology resident here at Methodist as well, also pushing things forward with glass. Let me switch back now. Let's see.
Okay.
And John, do we get any questions or anything like that?
Yeah, sure. First of all, Albert, excellent presentation.
Great. I hope it was a lot of stuff crammed into a little small amount of time frame, but and I try to make it look a little bit better with some fun pictures at least.
Excellent and very professional. Wow. Wow, you really set the bar high on that one. Yeah, there's a couple of points. First of all, I thought the most important part to me was the part, what's next?
Yes.
Because I think that you personally are going to play a big role in what's next, because you have an understanding not only of medicine but also technology and industrial design. That's a very unusual combination, and there's not many people around, especially with the advent of a technology like Google Glass,
right.
Which has, as you know, so much potential, and it can go in so many different directions, and it'll go in better directions quicker and more efficiently with people like you working on it. There's a couple of questions I have, and one of the things points that you brought up was when you talked about tele-illustrations, and that's something I'd never thought of, because we can do that. Like, we have a hangout right now, you and me. We can draw on the screen. There's a feature, so it just stands to reason you can do the same thing. While suppose I'm watching you do surgery, I'll be able to tele-illustrate to an unlimited audience.
Right.
The different structures, be able to draw on the screen, so that the other students can see the anatomy.
Exactly.
You know, I told a story in the last hangout of an operation I scrubbed in on a neurosurgical procedure where the field was very narrow. It was a laminectomy, and I don't know, you probably scrubbed in on those. The wound is not very big at all.
No, not at all.
For a student to look in there, and I can remember the neurosurgeon saying to me, and of course you're a student shaking in your boots, "Oh, do you see the disc pressing on the nerve?" And looking over, and I couldn't see a darn thing. But of course I said to the surgeon,
"Yes, absolutely.
Of course I see it," but I really didn't. But I think with Google Glass, of course, the surgeon's got the best view of anybody in the house.
Exactly.
If you can share that best view in the house with him, I mean, that's solid gold.
Exactly. No, I completely agree. So
that's yeah, and the tele-illustration is just another teaching point, which
exactly.
would help immeasurably with teaching surgical cases to anybody. You know, that this really does open up a lot more teaching potential.
Exactly.
Because just for what you said, the surgeon can be sitting where I am now, watching you operate, and can be commenting, could be drawing.
Exactly.
And of course, you operate on your own time. You're just basically streaming the video back. You're not really talking.
Exactly.
But I may be commenting on what you're doing. You see how Albert's doing this. You see this structure there, and you're concentrating, of course, on doing a good job surgical-wise. But I'm able to teach, and you don't have to teach. You know what I'm saying?
Exactly.
You don't have to stop and say, "Oh, wait a minute, here's this structure." I can do it, and I'm not scrubbed in. I'm just at another computer, talking, showing the students. So that brought another dimension to me, which I never thought about. That you can have a remote teacher,
right,
which is fantastic. You don't have to be a teacher at the bed in the surgical wound. You know, taking, you know how surgeons are. They want to get in and out as soon as possible, and they don't want to prolong this procedure, of course,
right.
For many reasons. Patient safety number one, but it's a measurable value to have a remote teacher. There's a couple of other things that you mentioned. And certainly something I can relate to, the ICU, and the fact when you mentioned the visual perspective. I know as an ex-emergency physician, the visual perspective is so important.
Exactly.
To me, because and I'm sure you're the same way when you rotate and you see patients, when you walk in a room and you look at a patient, you can't begin to tell the subjective value that gives to you.
Oh, exactly.
I'm sure you feel the same way. You walk into a room, and if you look at the patient's face, you can tell if they're in serious trouble just from looking at them.
Exactly. And these are things that just can't be communicated verbally over a phone. So.
No, it can't. It can't. It's just, if you eyeball it. And I was lucky enough to work with a nurse that had the talent of the same thing. She would walk in the room, and she would immediately run to me and say, "Dr. Bennett, you better move here fast. This patient's in trouble." And she was always right.
Yeah. I mean, exactly. I mean, you know, there's innumerable times where I catch myself saying it, and then also I've been asked it, and other people have been asked it, is you talk to your upper level, you talk to the attending on the phone, you're trying to describe a patient to them, they will inevitably go, well, how do they look? Yeah. And then you're stuck trying to describe this in your very subjective way. And you know, if you really had some sort of method to show them, you know, in of course, a secure way, then that is, you know, a picture is, of course, worth 1,000 words. So I think it gets the point across very quickly, one way or the other, and you know, it definitely increases everybody's efficiency and expedites anything that may need to be done for the patient.
How do the ICU nurses like it? They have to put it on, correct?
Yeah, of course. So we actually today received the 2 units from Pristene that we'll be using in the ICU and in the operating room. So we are going to be sitting down with the ICU attendings probably at the end of this week and try to work out a way to not only integrate it, because that's sort of the easy part, but how do we do this in a way that's structured and organized? We have a sort of like a study in place for it as well, so that we're kind of approaching this in a very scientific manner at the same time. You know, with new technology, especially things like this that unfortunately already gets a lot of bad press, and the general public doesn't even know what it is or what it can do. Especially if you bring it into such a sensitive setting like the hospital, you know, you really have to think carefully about how you approach doing it. So we're always eager to try out new things and bring new things in that we know are going to have some level of benefit, but to make sure that everybody knows that it's going to bring some benefit and is not going to be detrimental or change their plan of care is something that we need to be very careful on as we move forward. So it just takes a little bit of work, but I think we'll get there.
It sounds like an exciting place to work.
I'm absolutely fortunate. I mean, Dr. Barbara Bass was the one that built the entire Department of Surgery into what it is today, was responsible for spearheading Mighty, you know, brought me on board. She was the one that chose me not only for the fellowship, but, you know, to get my residency career started here. So it's a place that I definitely enjoy being at. Everybody is always about innovation, pushing things forward, helping people, both each other and also the patient population. So it's a great place to be.
Yeah, you mentioned Dr. Debakey was at that hospital, correct?
Yeah, so Methodist a while back was connected academically to Baylor. So Dr. Debakey operated at Baylor, but also did a lot of his operations at Methodist. And even to this day, you'll see hints of his things around. His coat hanger that specifically says M. Debakey underneath it is still hanging right by the operating rooms where he would operate, and they're not taking it down anytime soon, and nobody dares hang their coat on it. So, but it's a good place.
Yeah, he was quite instrumental in creating some devices, correct?
Exactly. You know, so everything, of course, you know, the carotid endarterectomy is one of his big things. just the story of him going to the fabric store and the only fabric they apparently had left that he thought was suitable ended up being Dacron, which ends up being the ideal thing. So definitely in a place where innovation is not something that people are unfamiliar with. So all the departments have people thinking in this way, trying to come up with new devices, working on new things. So it's a really exciting place to always be. It's not just about operating. It's about how do we contribute back at the same time as you get your training.
Okay, one question which I really wanted to ask you, as far as I envision you having a great future in design or redesign of glass.
Mm-hmm.
How do you feel about that? Do you feel that you can work with the shape of glass to modify it according to the needs of that particular medical niche?
I think there's a couple things that can be done to it, and we'll see if Google is up to it. I mean, I know they need to make a commercial product and not a niche product, so we'll see what happens. But there's already been people that have been doing it. There's people who have teamed up with people that make loops and gotten loops connected to the lenses that snap on. I think one of the big things that really needs to be done for glass is to install it onto a foldable frame to be put away. I made one for myself just kind of as a proof of concept, but my hope is that other people will do something similar, or like a Oakley or one of the other companies, or Luxottica, which Google said they partnered with a couple months ago to make new frames. I hope that's like the next evolution, because that really, it doesn't even fit in a white coat pocket. Like, I actually have to carry it around like a small purse if I have to use it, or I put it in my bag. If there's a way to make it more compact, that'd be really nice. Things specifically for the operating room. Once again, connectivity is an issue, and then really the other big one is battery life. And I know people have issues with that. And again, it's just, this is beta technology. Like, we're at such the infancy of this field, even though the piece of equipment is so high tech, and conceptually, it's really one of the most cutting edge things that's come out in a long time. But what it can do is still sort of rudimentary. It's like right now Google themselves can't even offer video chat on the system when initially they could. That's a very basic thing, and if we just had that, we could use it for the operating room. Actually, like the needs that you would want for it are so basic that the apps that are on phones like far exceed anything in terms of at least the coding that's necessary for them that we would need for the healthcare setting. At least for telestration, telementoring, teleconferencing, things like that. But I think it'll all get there. We're just about we're like a year in, a little bit more than a year into glass even being somewhat widely available. So it's very exciting that people like you and everybody else that's going to be at that watch conference are sort of all on board with seeing what can we do with this. We know that it has a lot of promise, but how can we push this to the next level? So,
well, Albert, I said in the last Hangout that when I first started this Hangout series about 3 weeks ago, I thought it was basically a niche surgical product, and I knew some people were enthusiastic about it. But what I've experienced in the last 3 weeks with doctors of all specialties, I haven't covered every single one, but many specialties, is not only the enthusiasm, but the hope for the future and the potential that each doctor professes where this tech will go. And it's tremendously encouraging for me after 3 weeks to see all this and to look forward to the Watch Conference, where a lot of it's going to come together.
Yeah,
so
absolutely. No, wonderful, wonderful stuff. So I wish I could be there. Next year I'll make it. So.
Well, you'll be there virtually.
I will, absolutely.
And anytime you want to have a hangout for any particular thing that you feel is newsworthy and the healthcare community will benefit, you're always welcome. And I thank you for our first-class presentation. Thank you very much.
No, thank you for the opportunity. If you or if anybody else wants to contact me, you can find me on LinkedIn at my name, Albert Huang, H-U-A-N-G, or my email is my first name, Albert, period, the letter Y, period, H-U-A-N-G @gmail.com. Happy to answer any questions. If you guys have ideas or things like that, I love just thinking about new stuff. So.
Well, now that you mention that, Albert, we are going to have a regular hangout on the weekends. I don't know if you're free on Saturday at 1 o'clock.
Uh-huh.
Or we can tailor it to your time have a hangout, an open call for someone that wants to talk about design. Is there any particular topic you would like to talk to people about?
You know, I'd have to think about it a little bit to kind of see what will be the next topic. But I'll definitely come in and kind of listen in on the next one and probably get some ideas that way.
Well, we've had some app developers, because my concept is basically to get doctors and developers together so they can more effectively develop glass apps.
Right.
But that would apply to you too.
Oh, absolutely. No, there's definitely software that can be used on the existing systems that could definitely benefit things for us. So.
Okay, well, I'll shoot you an email, let you know when it's going to happen. And
wonderful.
Thank you very much, Albert, and we'll be in touch.
Yeah. All right. Have a good night. Okay. Thanks again for the opportunity.
Thank you.
Take care.
Good night.